So we'll make a start. I know there's only a few people on the call, but I know that this time's not always convenient for everybody, so some people tend to watch them back. So I'm Sarah. For those that I haven't met before, I'm a prescribing dietitian. I work at Bob ICB as part of the medicines optimization team. The topic for today was going to be oral nutritional supplements and substance misuse, and just a general update around PQS. Before we move on to those topics, was there anything that people particularly wanted to ask about PQS, or are you all getting on okay with it? I'll take that as you're getting on okay. All right, so I'll just go through PQS reminders and then we'll move on to the substance misuse topic, if that's okay. So just a reminder that everybody needed to submit a standard operating procedure for the PQS by the 31st of August, and you would have got 5 points awarded for that. If you haven't done your SOP, we still encourage practices to consider doing that because it will help you achieve your PQS target. And if there's any reasons why you haven't been able to submit it within that time frame, then please do contact me and we will consider those on an individual basis. Just a reminder that we've got some templates on SharePoint. So there are some templates for when you're emailing dietitians to clarify their prescription requests, and also some AccuRx messages that you can use with your patients as well if you're trying to understand their current weight, or if you're trying to give out some information around oral nutritional prescribing as well, particularly if they've been initiated in secondary care. We also have a dashboard as well that we have changed slightly. So the dashboard will give you an idea around how you are progressing with your PQS target. And we've changed it slightly in that you now have, there's two tables here, one that tells you how many patients that you have on your non-preferred ONS, sorry, how many items you have for your non-preferred ONS, and how many items you have for your overall oral nutritional supplement prescribing. And there's a little chart there telling you your monthly breakdown. So what percentage of your ONS prescribing was for the non-preferred, and then you have kind of a league table at the bottom there explaining how you're getting on with your overall kind of adherence with achieving your PQS target as well, because we are going to be looking at your performance on a 9-month rolling basis. So we'll be rewarding a points on your average performance. So I have had a few queries from some practices around that. So hopefully that clears it up. And just a reminder around the products that we are targeting in the PQS. Some of the products are the 40-sip bottle, the 40-sip compact, and the 40-sip compact protein. So remember, the ONS target, the PQS target is around oral consumption of those nutritional supplements. All of those 3 products are on our tube feeding formulary. So if you do get a prescription request, do check whether it is for oral or enteral use. And if the prescription request has come from a dietitian, please contact them before amending. And I have had some other queries from practices as well, just saying that they have got patients on these non-preferred oral nutritional supplements, and either the patient is adamantly refusing to switch to an alternative ONS, or the prescription request has come from a dietitian and it's because they can't tolerate any other product. So you won't be penalised for using the non-preferred ONS. We just need to make sure that they are being used as a kind of last resort, I guess. And if you do feel that you have got some patients on your caseload still that are using those non-preferred supplements, then I would start keeping a log of that rationale. Like I said, we'll be monitoring your performance on a 9-month rolling basis. So at the end of the financial year, we will pull our EPAC data to see how you've performed. And if any practice feels like they have done their best to achieve their PQS target, and there's been, reasons outside of your control, i.e. patients that can't tolerate any of the other supplements, then you can submit an appeal and we can look at that on an individual basis. So I would start keeping a list now if you do feel that you have still got some patients on those non-preferred nutritional supplements. Any questions before I move on to substance misuse? No. Okay, so the topic that we were going to look at today was ONS prescribing for substance misuse patients. So Just to kind of set the scene, in terms of guidance around using oral nutritional supplements for in substance misuse and drug dependence, the UK guidelines state people who use drugs or may suffer from poor nutrition, but should only receive oral nutritional support if there's a clear medical reason. So the substance misuse wouldn't be the ultimate reason why somebody potentially needs those oral nutritional supplements. Ultimately, a request for oral nutritional supplements would be assessed by a GP, and they should take into account their clinical assessment and the patient's body mass index. Patients should be given advice on diet and nutrition, especially if they are have a heavy alcohol intake. And we may need to think about thiamine supplements if they have the context of problem drinking. So I thought I would just give some reminders out about thiamine and refeeding syndrome as well. So in line with NICE guidance, all thiamine should be prescribed for the prevention of encephalopathy for harmful or dependent drinkers, in whom many of the following apply. So if they are malnourished or at risk of malnutrition, if they have decompensated liver disease, or they are in acute withdrawal, and before and during a planned medically assisted alcohol withdrawal. And the recommended dose is 200 to 300 milligrams per day in divided doses throughout the day. And thiamine should be continued for as long as malnutrition is present or during periods of continued alcohol consumption. Following successful alcohol withdrawal, thiamine should be continued for 6 weeks. If after this time the patient remains abstinent and they've regained adequate nutritional status, thiamine can be discontinued, but it should be restarted if someone's alcohol intake resumes. And the continuing need for the thiamine should be reviewed at appropriate intervals, which will depend on individual circumstances. So that's just a refresher on the guidance around thiamine prescribing. And with regards to refeeding syndrome, you might find that potentially a patient with substance misuse may go into hospital setting and then come out with a set of vitamin and mineral supplements, and sometimes it can be difficult or people forget that they are only needed temporarily. So patients with little or no nutritional intake over a period of time, and like we said, that includes people with alcohol dependence, may be at risk of refeeding syndrome once feeding has started. So this risk is usually identified in the acute setting or whilst somebody is under specialist care. NICE recommends that a patient at high risk of refeeding syndrome should be prescribed the following for the first 10 days of refeeding, so or reintroduction of nutrition. So that can be either enterally or orally. And again, they would need that 200 to 300 milligrams of thiamine. And if someone's, like we said, a problem drinker, that might need to be on an ongoing basis. And they would also need vitamin B co-strong 1 or 2 tablets 3 times a day, and a balanced multivitamin or trace element. Typically you'll see Forceval prescribed, but for refeeding syndrome that is only for the first 10 days. We do often see those items can be continued on an ongoing basis. So when we think about people with substance misuse, the typical things that we tend to see in terms of nutritional related issues can be poor appetite and weight loss, constipation, nutritionally inadequate diet, and dental decay, particularly people who are drug misusers. You will see the dental decay and the constipation. The reasons for the nutritional related problems are multifactorial, really. The drugs themselves can cause poor appetite and a reduction in saliva pH, which leads to dental problems, constipation, and craving sweet foods. People often don't really do good or undertake good dental hygiene, so then that affects obviously the quality of their teeth. They may have a lack of interest in food and eating, poor memory as well, so and often chaotic lifestyles, and therefore hand in hand goes with that irregular eating patterns. Potentially they have poor nutritional knowledge and skills. They may also be on a low income intensified by the increased spending on drugs or alcohol. They may be homeless or have poor living accommodation, so they don't have access to, poor, well-equipped kitchens. They may also have infection with HIV or hepatitis B and C, and if they're on treatments for those things, that may also impact their nutrition. Poor access to food. They may also have an underlying eating disorder, which coexists with their substance misuse as well. So there may be lots of factors that are affecting that individual's nutritional intake. The challenges with prescribing ONS in this patient group can be, once started, it can be difficult to stop. It can be used instead of meals. So whenever we prescribe oral nutritional supplements, it's always in addition to what that person's eating. There may be niche situations where somebody is using oral nutritional supplements for their complete nutritional intake, but I would say that's few and far between and would be quite niche situations. So perhaps somebody has got esophageal cancer and they can only tolerate liquids. So you may be looking at a liquid-based diet. They may be given to they may use them to give them to other family members or friends. They can also be sold as a source of income as well. And it can be hard to monitor the nutritional status and ongoing need for a prescription, as sometimes patients in this group may find it hard to attend regular appointments or, may DNA, and then you're left not having the monitoring to know if that prescription remains appropriate. What we would say in terms of prescribing criteria, it's the same for the main population. We would only consider that you would be looking at prescribing oral nutritional supplements if somebody has a BMI of less than 18.5 or they've lost more than 10% of their body weight in the last 3 to 6 months. They also have a coexisting medical condition which could affect their weight or food intake that meets the ACBS criteria. Substance misuse is not an individual criteria to point to needing a prescription for oral nutritional supplements, and they should have tried food first advice as well. So if ONS is deemed clinically appropriate, and like we said, we would be using the same criteria to initiate a prescription as we would for the main population, we suggest following our quick guide on malnutrition and oral nutritional supplements that I've linked there on the slide and is available on our website. We would suggest that you avoid adding ONS prescription requests to the repeat template. If you are initiating that prescription, you need to set clear review plans with the patient and explain if you don't come to your appointment, your prescription will be paused. We shouldn't be having a prescription for longer than 1 to 3 months. And if there's no change in weight, so i.e. there's been no clinical benefit to that patient after you've started the ONS, then again, the prescription will be reduced or stopped. And that's the same guidance that we would suggest for any oral nutritional supplement prescription. If weight gain does occur as a result of that implementation of that prescription, we would suggest continuing it until the treatment goals are met. And if the individual does want to continue using oral nutritional supplements, you would then signpost them over to homemade supplements or over-the-counter drinks as well. We've got a couple of case studies on this slide here. So the first one is somebody that came into GP practice. Their daughter bought them because they were worried that they were losing weight. They were drug dependent and they were asking for energy supplements. The person's body weight was 48 kilos. They had a BMI of 20. And then the second case study is somebody that came in with their partner. They were using crack cocaine, spending about £30 a day or more, and they weren't eating very much. And their partner was really concerned that they were losing weight and they looked very skinny. So what would you do in this situation, and how would you manage that request for supplements? Or have any of you been in those situations before? Anybody want to put anything in the chat or put your hand up? So I think the points to consider are screening those individual patients for their risk of malnutrition. So complete the malnutrition screening tool or MUST screening tool. Yeah, thank you, Sarah. Yeah, that's exactly right. Think about your MUST score, and also think about what the underlying reasons are for that malnutrition. So we obviously put on the previous slide there what can be some of the issues that people who have substance misuse may be living with and what could be affecting their nutrition. But it's understanding it from that individual patient. So what's that patient's view of their weight loss? Are they concerned? Because in both of those situations, it was somebody else bringing that person into practice saying that they're concerned about the weight loss. What's their living circumstances, so trying to find out what their cooking facilities are like. Do they have anything affecting their appetite like constipation or dental issues? Have they got, what's their budget for food, and what are they currently managing to eat as well? And then also thinking about, is there any other coexisting medical condition that could be affecting their nutritional or food intake? And also talking about the opportunities with them about food first. So if they've come into practice saying that they're worried about their weight, what have they already tried? Have they done anything already? So that would be helpful to explore that option with them as well. And then set an appropriate, based on the information that you glean from asking and taking those measurements, set an appropriate aim of treatment. So it could be that we want to look at weight maintenance or preventing further weight loss in the first instance. We have those quick guides that I've mentioned before that would help you think about the kind of criteria that you need to consider, and also an FAQ around ONS for adults as well that talks about prescribing for this patient population as well. So they can be handy things to refer back to when you have a patient with you, or you're looking or reviewing somebody's prescription as well. So what happened in both of these situations? The patients were both prescribed oral nutritional supplements. So for patient 1, they were prescribed Ensure Compact once a day, and patient 2, they were prescribed Ensure Plus Milkshake once a day, and also encouraged to prepare homemade supplements. In both of those case studies, neither one had a must score completed. Food First wasn't fully explored. So I guess in case study 2, they were given supplements and told to do Food First. So I guess they haven't had an opportunity to actually use that Food First as an approach for managing their malnutrition. There wasn't a clear goal or rationale documented for the oral nutritional supplement. So therefore, it's going to make it difficult to monitor or deprescribe in future because there wasn't an agreed goal with the patient. Once a day dosage is also not a therapeutic dose for either of those supplements. And really, it feels like ONS was given as a treatment or fix rather than tackling the underlying problems. Now, that's an easy, I guess, a sweeping statement for me to make there. It's difficult, isn't it, when you've got that patient sat in front of you, when you need to think about clinical risk as well. And also, you know, we only had an individual weight there for the first patient. The BMI was 20. It would be difficult, you know, that clinical risk could have been greater for that person if we knew what the previous weight history was as well. Also, ready-made oral nutritional supplements are our second line. We prefer powders to be used in the first instance where possible. So if they do have facilities or cooking facilities, an ability to store milk, then we would be looking for them to use powders in first line. Both of those products, the Ensure Compact and Milkshake and the Ensure Milkshake, are non-formulary as well. And for Compact, we actually have prescribing restrictions in place because the nutritional content of an Ensure Compact compared to Ensure Plus Milkshake is exactly the same, but it costs significantly more. So we do advise that compact products are only used for people that are having difficulty drinking adequate volumes of a standard supplement, so i.e. the Ensure Plus Milkshake, or if they have a clinical contraindication to needing a smaller volume, so if they've got dysphagia or they have liver disease or they're on some type of fluid restriction, they would be the other instances where we would expect a compact product to be used. The other thing to think about is obviously if you've got somebody in front of you that's asking for supplements and it's because they don't have, you know, they're saying they don't have money for food or they don't have cooking facilities, is also thinking about what's available. So I'm sure you've got social prescribers in your practices, or some of you may have, and also thinking about where there's free and low cost services. I think cost of living is affecting lots of people these days, and all our local councils do have good signposting information around where people can access free meals, or you can get you know, there's like community initiatives around community larders and those things as well. So I would say, and obviously there's like food banks and things like that. So I think it's assessing those individual patients and looking at the clinical risk as to whether it is properly appropriate to start an oral nutritional supplements. And if that isn't the case, then there are other places to signpost patients to as well. We also have over-the-counter options as well. Now, appreciating some patients, you know, they may not have the money or the means to purchase those, but it can be a useful thing to signpost people to as well. So we have that available on our website as well, and I just summarized it there in the slide. So I'm sure you'll all be familiar with things like Complan, Mirateen, and there's Ames Retail option as well, and New Life as well. So it can be helpful to guide people to those as well. That was my main topic that I was going to talk around, substance misuse. Have you got any questions or queries on those bits? Or has anyone got any patients that you've had this experience with, having to review patients prescribe supplements when they have a substance misuse diagnosis as well? Okay. The final thing that I was just going to touch on is just a reminder about our position statement around ONS and care homes. That came out in September. It's available on our website, and it just reminds care homes and primary care colleagues that we don't support the routine use of oral nutritional supplements for care home residents anymore, and that care homes should be using a food first approach to manage residents at risk of malnutrition. There are exceptions to that recommendation, and that would be if somebody's tube fed. So if they're needing to put that supplement down a feeding tube, then we would still support use in that scenario. Or if a resident has diagnosed dysphagia requiring use of a thickener, then we would also support the use of a thickened supplement. Or in exceptional circumstances where a GP or a specialist practitioner, such as a dietitian consultant or care home support service nurse, may recommend that ONS is the only thing that alternative to support an individual's nutrition. We have lots of training sessions going on at the moment that we've invited all our care homes to. So we would like just your support with encouraging care homes to sign up to those training sessions, and a reminder about that training and how to register is on the slide as well. And then we have our next session, our next Lunch and Learn will be on the 23rd of December at 1 o'clock, and it will be related to pressure sores. So that brings us to the end of today, unless there's any other questions or queries that people have. Thank you everyone for logging on then. I will sign off then and just let me know if you have any questions or queries relating to nutrition. Thanks for your time.